The House Committee on Families, Children, and Seniors will now come to order. Madam Clerk, would you please read in the letter from Speaker Joe Tate?
Dear Mr. Clerk, I am making the following changes to the committees for the 102nd Legislature. Representative Neil Frisky will be removed from Families, Children, and Seniors. Representative Jamie Thompson will be added to Families, Children, and Seniors. Sincerely, Joe Tate, Speaker of the House.
All right, thank you for that. And now, Madam Clerk, would you take the roll?
Chair Young.
Present.
Representatives Coffia.
Present.
Glanville.
Present.
Arbit. Edwards. McDonald.
Present.
Wozniak.
Here.
Fox. Johnson.
Here.
Thompson. Madam Clerk, you have a quorum.
All right, thank you so much. Representative Wozniak makes a motion to approve the minutes.
Yes, I do.
Thank you. And with that, we're going to go ahead and get this party started. Because this is, look, this is how we do things in families. Hey, it's so important. The work that we do for our families, you know, it's so crazy when I have to say for our families, for children, for seniors, but that's really what the community is made up of. And so we take our roles very, very seriously. And so with that, I would like to go ahead and bring up our speakers for today. All right. From the Michigan Department of Health and Human Services, we have with us Dr. Sarah Lyon Calio. Kello, okay, I'm like, is that an I or O? Kello, Acting Senior Deputy Director, Public Health Administration at DHHS, and Karen Spiedel? Spiedel, all right, oui. Acting Division Director, Division of Environmental Health for a presentation on the Childhood-Lead Poisoning Prevention Program. And so with that, I'll let you all have the floor. Thank you so much for being here today.
Good afternoon, and thank you to the Honorable Chair and Committee for your time today. Really appreciate the invitation. As requested, we do have a brief presentation about the Michigan Department of Health and Human Services Child-Led Poisoning Prevention Program and its components. So I'll go ahead and get started. I'm going to touch on 5 topics today that you can see listed there regarding lead exposure, a description of the program, and its future directions. But I first wanted to talk about what lead is. Lead is a heavy metal, toxic to humans once it enters the body, and it can cause irreversible harm. So why is it in our environment? Lead's chemical properties made it widely used in manufacturing, including being in paint prior to 1978, being in gasoline prior to 1975, and being in plumbing before 1986. Because of these historic uses, lead is found throughout our environment, and we have resulting lead in dust, soil, drinking water, food, and air. The presence of lead is particularly problematic in those homes that are built before 1978. So most people in the United States have had some exposure to lead, but there are individuals and communities that experience far greater risk of lead exposure. This inequity exists because of aging housing and infrastructure in communities, as well as proximity to past urban and industrial practices. Communities that lack resources to address this lead face inequities in protecting their children from lead exposure. Children from low-income families living in pre-1978 homes are often at greatest risk of lead exposure, which can be particularly impactful for communities of color. Once lead enters your body, harm can occur. The developing fetus and young children are at greatest risk of the irreversible harm of lead on development, particularly in brain development. There is no safe level of lead in your body. However, in addition to harm to children, lead can also harm adults by impacting kidney, cognitive, cardiovascular, and reproductive functions. So in 1998, the Michigan Public Health Code was amended to add the establishment of a lead poisoning prevention program, including its components and reports. The Public Health Code calls for a plan to prevent childhood lead poisoning and to minimize exposure to the general public to lead-based paint hazards. The code also calls for an education and community outreach program with materials to the public, child care providers, healthcare providers, and schools. It also calls for technical assistance to be provided to healthcare providers and for this department to communicate and provide technical assistance about elevated blood lead levels to local public health. So how do we know who has been exposed to lead? The Centers for Disease Control and Prevention defines a blood lead reference value that is set to determine when a child needs environmental and medical response to address lead exposure. Children with elevated lead exposure need local public health case management assistance, investigation of their household lead sources, and then interventions that range from education to construction assistance called lead abatement. MDHHS identifies children with elevated lead exposure through blood lead tests that are reported by healthcare providers to the department. In May of 2022, we adopted the CDC's new lower blood lead reference value, resulting in more children in Michigan being eligible for the environmental assistance and case management programs that we offer. We also evaluate blood lead data for patterns in communities that may require a public health response. For example, we want to make sure children who need blood lead testing are getting it. From the chart on this slide, you can see that in 2020, the number of children tested for blood lead in the state declined. The start of this decrease in the number of children being tested aligned with the start of the COVID pandemic. We have taken actions to address this decline, including conducting healthcare provider education, conducting a multimedia educational campaign targeting parents and caregivers, and holding community blood lead testing events. The number of children being tested for blood lead remains low, with slight indications of improvement. This is a summary of the recommendations that the program works to implement. You can see we have recommendations in the areas of blood testing, in data and surveillance improvements, in case management for children with an elevated blood lead level, for community education, and for linking to environmental services. And we're going to go through each of these in a little bit more detail. So blood lead testing is primarily conducted through a child's healthcare provider at those preventative visits. To increase child blood lead testing, MDHHS has launched a statewide media campaign to encourage parents to talk to their child's healthcare provider about the need for blood lead testing. And we've worked with local health departments to conduct community blood lead testing events in targeted areas. In terms of data and surveillance, we've made investments to improve the quality and timeliness of blood lead data received from healthcare providers and laboratories. And it's important that we get that information about child's blood lead levels so that we can connect them with programs quickly. We have also integrated our blood lead results into the My Tracking data portal, which allows public and professionals to access statistics on blood lead testing and elevated blood lead levels by location and year. The information on My Tracking data portal is available down to the county level and can be used to look at patterns over time. MDHHS assists local public health departments as they provide services to families with a child who's experienced an elevated blood lead level. This includes blood lead case management services and referral to environmental and health services. Later this year, MDHHS will launch a new case management data system that will bring together the environmental, housing, Medicaid, and blood lead level information, allowing for more efficient and comprehensive documentation of child case management services and response. This will aid in the coordination of response for children. I mentioned that we had invested in a statewide multimedia education campaign that launched in 2020 and continues currently. We've implemented online learning modules for healthcare providers about lead and for health professionals that visit homes. We are also working at a community level, focused on communities with extensive lead hazards, participating in local events with educational materials, and again, conducting community blood lead testing events with local partners. So finding and fixing all the lead hazards in a home, including paint, dust, water, and soil, is key to preventing child lead exposure. The department operates a program for families on Medicaid that identifies household lead hazards and implements repairs to remove those hazards. This is important for addressing homes where children have an elevated blood lead level, but also in some areas of the state, we're able to address households where children are enrolled in Medicaid live regardless of their blood testing status. The repairs can be extensive, as shown in this before and after photo on this slide. We result in children having homes that will not threaten their health from lead exposure. MDHHS has launched also the Lead Prevention Fund for those who are not eligible for a Medicaid program but need low-interest loans to fix lead hazards in their home. We provide the home investigation to identify the lead hazards and then provide confirmation that the work was done completely and appropriately. So some home lead inspections result in a public health investigation that requires more complex analytic testing. So I want to take you through a story about a child who had a very high blood lead level, requiring medical intervention. And the initial lead inspection of their home did not find an obvious source of lead. The child's elevated blood lead level did not appear to be caused by paint, dust, or water. The investigation team noted that the family used a variety of spices and that some of these spice samples were found to contain lead. Fortunately, the MDHHS Public Health Laboratory has unique capabilities to identify the different types of leads that are in samples from the environment and from human blood. Using this technology, we're able to show that the type of lead in the turmeric that this family was using was the same as the type of lead in the child's blood. This confirmation allowed our child case management staff to demonstrate to the family that their source of turmeric was poisoning their child with lead. So this case illustrates the value of child blood lead testing beyond the current approach, and that expanded blood lead testing is a valuable action that can prevent lifelong harm from lead. So our future work with the program is addressing all those recommendation areas that I went through. But I wanted to focus on a couple of things here. We're going to continue to focus on education, particularly around the new blood lead reference value for healthcare providers. We're also going to work to continue to expand blood lead testing and target resources to vulnerable households and vulnerable communities. So I want to thank you very much for your attention today, and we'd be happy to answer any questions you may have. Thank you.
All right, thank you so much for your presentation on today. While you ended it with an eye-opener. Oh my goodness, I had no idea there were spices that contain lead like that could potentially give a child lead. I personally did not know that, so thank you for sharing that with us and so that we'll be aware. I'm just wondering about the labeling on these spices and labeling on these things that could potentially cause a hazard for children and families. One thing that I wanted to mention is when I reached out to you all, for this update, it started with me looking at your last report that is supposed to be an annual report due to the legislature each year. I know that we kind of missed a year, so if you could go ahead and share with us when we can expect to see a report so just the members know what's going on with that.
Sure, and I'd like to apologize for missing the 2021 delivery of that report. It was certainly not our intention. came to our attention when you asked about it, and as we were preparing the 2022 report, which was about to go into review when it came to our attention that the 2021 was missing. So what we've done is ask staff to go ahead and combine 2021 and 2022 together. I expect that will be in our review process by the end of this week, and we'll get it to you as quickly as possible.
Okay, very good. Thank you. Because when I look at what you are looking at in terms of recommendations now and recommendations then, things still continue to align. But I did want to ask you about the ensuring the appropriate public health case management and intervention statewide when a child is identified with an elevated blood lead level. I just need you to just do a little bit more of a deep dive in terms of what that looks like, if you could.
Yeah, sure, I can cover that. That's a great question. So when a child's identified, well, first of all, let me back up. Our childhood lead poisoning prevention program, as Dr. Lyon Callow covered, starts with the data coming in, right? So when any individual in the state of Michigan, so children included in that, are tested for lead, regardless of result, all of those results come into the department. At that point, under our surveillance program, those children with identified elevated levels go out to local public health. So there's a process for that in terms of data sharing. When local public health receives that list of children with elevated results in their jurisdiction, they immediately assign that case to a public health nurse at the health department. And the public health nurse makes contact with that family to schedule. Usually the first step is just a quick conversation followed by a home visit. So the public health nurse will typically go out, sometimes accompanied by a sanitarian, but generally it's just the public health nurse, go out to the home, talk through the results with the family, and then talk about next steps. So they do a quick walkthrough of the home to do sort of a visual. Is it an older home? Is there likelihood of lead paint exposure? Any other things? Are there spices perhaps that maybe look suspect? Toys, dishes, furniture. And then the public health nurse will go into a bit of the sort of follow-up care that happens. So generally talking about the retesting schedule for the child to make sure that the interventions that will be put into place are addressing that child's level and the level is going down, as well as additional referral services, generally for things like early on educational services and other types of special education services.
Okay, that helps me. So during that time, I got a couple of members who have questions. I just a couple more. Indulge your chair. A couple of other things. So when we're looking at making certain that our children are safe, how important is a healthy diet? We've already identified that these are young people who are living in potentially, underserved areas, lower income areas, households. How important is a healthy diet when we're trying to address these types of impacts of lead?
Yeah, that's a huge part of that. And in fact, that's something that's covered that I didn't mention is in the nursing case management visit is around a healthy diet. And so we have a variety of different educational materials that the public health nurse will go over with the family in terms of a balanced diet and iron-rich foods and that type of thing. And then additional, as part of those referral to services, it can be sort of a referral to SNAP or referral to WIC services, whatever it may be, gaps where maybe that particular family is not already signed up.
Okay, thank you for that. Representative Glanville.
Thank you, Madam Chair. I actually have a couple of questions too, if I may. First of all, I just wanted to, one thing I wanted to understand better is that testing piece. Is that universal? Or is this a child only tested like when they present with symptoms?
So currently, the expectation is that children are screened to assess whether or not they need to be tested. So depending on where the child is, the age of the home that the child is living in, if a child is on Medicaid, there is a automatic testing schedule that should go through. So right now, we do not have universal testing. We have universal screening, and that screening questionnaire is what the physician would use to determine whether or not they would test that child, in addition to their clinical judgment, of course.
So would every child be screened, or again, only if they are maybe in a particular neighborhood, like identified area, or?
The
Yeah, I can take that. So generally, every child should be screened at 1 and 2 by the provider, and then it's the provider's responsibility, at least at this point in time, to determine, based on the answers to that risk questionnaire, whether that child should be referred for testing.
So where my mind is going with this is I'm just trying to think of how we can lift up those testing levels, and I'm wondering if there's some mechanism similar to childhood immunizations where we just automatically check children at a certain age or something along those lines. So just like I said, my mind is just kind of working. And with that in mind, I was wondering if there's any partnership with the CAHCs, what is that? Let me see. Hang on, Child Adolescent Health Centers. Do you partner with them at all?
Yep, yes. So there is some partnership with those folks. Generally, we find that the children within those centers are older than the age we want to catch it sooner, right? So, for example, the Medicaid requirement is that if a child's enrolled in Medicaid, that they must be blood tested at 12 and 24 months of age, or once before the age of 36 months. Generally, what we've found is that those children are not receiving their primary care through those centers, and so it's not we're not getting the greatest benefit there, right?
Because those start with age 5, as I understand it.
Yes.
Yeah. Okay. So, and then what happens if a child moves into a neighborhood? So if they're 12 and 24, do they get? I mean, if you move again, just like thinking about where there's some gaps here.
Yeah, I think that that would have to be on the provider for sort of screening. Unfortunately, at this point. In the screening questionnaire, it does ask about age of housing, if the parent or guardian knows what the age of housing is.
Okay. So just 2 more, I think, if I may. I was wondering, when it comes to the abatement, you mentioned that if you are Medicaid eligible, making repairs to your home would be covered, but if you're not, you get a low-interest loan. Okay. So that feels problematic to me, so just flagging that.
Yeah. So can I add
Yeah,
to that?
please,
So currently we have, Michigan was first in the nation in 2017 to receive the Medicaid Health Services Initiative, which is the funding to support lead abatement. And with that, so we have, as Dr. Lyon-Callow mentioned, we have, target areas under that particular funding source where we can do primary prevention, which is getting in and fixing the home before the child's exposed. In addition, that funding source serves as a safety net for cases where a child's already been exposed anywhere in the state, if the child's enrolled in Medicaid. We do have another, pot of funding that we can look to for providing lead abatement to low and moderate income families. It's very limited. So it's, it helps fill the gap. And then with the lead prevention fund, that's an extra sort of safety net with that.
Okay, great. I'm just so you know, I'm from the Grand Rapids area, and
Okay,
so we
yeah.
have a pretty, for those of you on the committee who don't know, we have a pretty very engaged in lead abatement in our community. It's been quite an issue for us. So final question, again, just looking for gaps in places we might be able to fill them. Is there any requirement, for lack of a better word, on point of sale of homes? So similar to having your home inspected for any other issue at point of sale, is lead included in that?
Not currently.
Okay, all right, thank you.
Yeah, that was something I was working on last time.
That's all.
No, that's all good and very important. Thank you for that. Next up, we have Representative Fox.
Thank you very much, Madam Chairman, and thanks for those good questions. I really like some of those too. My questions are, I've got 3. One, do you ever have to have CPS involved in your situation with lead problems?
We do occasionally,
Okay.
yes. I think one of the primary messages that we try to give families up front in the process when they're enrolled into nursing case management or enrolled and then ultimately enrolled in abatement services is that we are there to help. We are not, we have to separate ourselves a bit from, even though we're the same department, from CPS. We are there to help. We are not to take children away. However, occasionally we do run across situations where perhaps the residing family doesn't have the means to be able to kind of work through this program and the system that's been set up. And so occasionally we do have to engage CPS, again, to get to the point of resolution where we can make sure that the family, the children, the parents, the guardians, and siblings are all residing in a lead-safe home.
Okay. Then second, thank you. And second question goes to how do you treat lead poisoning? What, you know, and you don't have to give me the long answer, just is there, you know, what do you do with lead poisoning?
So since the primary treatment is prevention,
Right.
and ultimately if a child has a level, the best route of treatment is removing the source of exposure from the child's environment and time, quite honestly. Now, in cases of children who have extremely high levels, and in the medical world, it's typically 45 micrograms per deciliter of lead in the blood, those children will be typically admitted to the hospital and go through what they call chelation therapy, where they're pulling the bad stuff out and putting better stuff in, right? But it's a very painful, but very long process that the child has to go through, and very, of course, traumatic for the families.
Okay. And the final question, very honestly, is for my wife and daughter. When you mentioned turmeric, and it just takes me to conversations, both of them are nurses. My wife often tells me, well, you have to watch where you buy, where that was made, you know, this toy or whatever. And this is my daughter too. And also the spices jump out at me too. Do we have to watch where our spices are coming from? Like they often talk about, buy garlic that's grown in the U.S. is the way that they talk about it. Are there things we should be looking for? And are there ways that our country and our, you know, those who are selling these things can help us with that?
Yeah, this is a tough area for me to talk about because what we typically find through our environmental programs when we're going into a home and assessing where the child's been exposed, and when it's not the house itself, right, the paint, the dust, or the soil within the house, and it's something else like a food or a spice or a candy, we are generally finding that they are imported, and many of the times, not all the time, but many of the times, the family has brought back those products with them from the country of origin. But the other issue I think to point out is that we have a lot of sort of small grocery chains, not even chains, small grocery stores, right, in communities that may be selling imported spices and food substances and that type of thing. And that is that's a large issue. When we learn of those things, we work with, you know, whether it's MDARD or if it's an actual product, the CPSC, to notify, like, for example, a toy in that. But it is I would say, a gap that could be corrected at a higher level.
Mm-hmm. Okay, thank you very much.
Welcome.
Representative Johnson?
Thank you, Madam Chair. Great presentation, and I know there's some clinics, outpatient clinics too, that offer the chelation. Can you comment on the data? There's more than ample data now showing that childhood vaccinations show heavy metal poisoning, including lead, and therefore there's been, you know, efforts to chelate and do other things like that. Could you comment on that data?
Do you have data like that? If you don't,
I
then
want to
you
make
don't.
sure I'm understanding the question. I don't have data that shows that there is lead in vaccines or that
Okay.
we have children who've been vaccinated. And
Okay,
resulted
very
in
good. Thank you.
I'm
Next
happy
would-
to help you with that.
Okay, Representative Kofia?
Thank you, Madam Chair, and thank you for our presenters today. So I wanted to follow up on the point of healthy diet for children as being important for helping mitigate possible lead exposure. I'm looking at a health department brochure here that talks about children with empty stomachs absorb more lead than children with full stomachs. And, you know, you named that some of the populations here in Michigan who are most vulnerable are lower income communities, communities of color. So I was looking at the list of foods that are supposed to help combat particularly iron-rich foods, meat and seafood, vegetables, fresh vegetables, nuts, fruits, etc. And I wonder if your departments are starting to encounter the issue of the recent cut in SNAP benefits, started at the beginning of March, and the impact of that in terms of these vulnerable families having access to enough healthy foods to mitigate lead poisoning?
Yeah, I don't believe we have data that shows an impact of that cut specifically on our lead, our families served by our lead case management program.
If you could keep an eye out for that, because the cut is a federal cut that just occurred. It was over the pandemic. They expanded the funding for each family to receive for SNAP benefits, and it's now been cut. I don't know what the number is exactly, but it started at the beginning of March. So what we're hearing from our food pantries is that they're getting an influx of those families trying to make up the difference. And of course, food prices are high. So just to flag your department to be watching for that, unfortunately, it's going to, I think, mean less access to those healthier foods.
Thank you for that.
Yeah, thank you for that, Representative. Yeah, that's really a big deal for us, particularly those of us on this committee and beyond. Because I heard you say during your presentation that one of the things you do is share with families resources like SNAP. And so now that we know that those benefits have been rolled back to previous year's benefits, but in reality, if I used to get like $70, and then for 3 years I started getting $280, and then all of a sudden I'm back to $70, I got accustomed myself and my family, to living. And so, yeah, I've reached out to some folks at the congressional level to say, do you realize what just happened here? But in addition to just us wanting to be mindful that when we're recommending families as a solution to go to our food banks and our pantries, that they're already strapped and needing additional support. So that's one of the reasons we want you guys to know about it. And if things come up, perhaps you can help document. Well, we referred some people. They came back to us and said, my local pantry wasn't able to help us. We need to know about those types of things as we're working to find a way to support our families here in Michigan. So thank you so much for that. Mr. Minority Vice Chair, Representative Wozniak.
Thank you, Madam Chair. Nice report, great. The numbers look great. In your report, you point out Flint to be a hot spot in the state, and I think Benton Harbor is on that list too. Are there still prevalent hot spots in the state, and do you know how many there are or where they're at? Are they more rural or urban? Then I got one more question.
Okay, yeah. So there are still hot spots. And within our childhood lead poisoning prevention program, we also release an annual data report, which is just a lot more in depth in terms of what we're seeing related to geographies with, in highest number of children with elevated levels. So there are, just sort of off the top of my head, Grand Rapids was mentioned. Detroit is there is a lot of older housing in Detroit, and so that is a real hot spot. So generally and there are many others. Generally those are they're urban areas. That's because that's where the majority of testing is happening. Not to say the rural areas aren't of concern, but we're seeing the highest number of children within urban areas.
One more question. What are you doing for pets? Pet lead poisoning.
We have come across that a couple of times in my time with the programs. So because our care is primarily focused around the child, it's kind of interesting though, even because it's focused around the care of the child, the pet is still part of that because the pet is interacting typically in the environment where the children are. So I guess the best example I can provide is in terms of a pet being outside within the soil of the home, tracking that soil back into the home where the child or toddler or baby may be on the floor and accessing that dust or soil. I think the other part in terms of directly to pets that we have looked at more recently is in terms of water. So using exterior hose bibs, so where you would go and hook up your garden hose, those are not regulated for lead, and they're not supposed to be used for drinking, but a lot of folks use those for watering of pets. And so that's an area that just kind of indirectly has come across in our work.
So I don't mean making light of kids, but the kid could get lead poisoning from the pet. Is that right?
Through tracking, so the pet bringing in that dust, soil, and the child either being,
Right.
playing with the pet, or indirectly the pet bringing that in and the child being on that floor.
Okay. Thank you.
You're welcome.
Sounds like you all are advocates of the take your shoes off before you start walking through the house, right?
Absolutely, yes.
Right, and wash the pet's feet too.
Yes.
Okay, very good though. This is wonderful. Representative McDonald.
Thank you, Madam Chair. I was just curious in your story about turmeric. When that happens, do you then make sure you know the source of the lead in the turmeric? And does someone take over and trace it to a store or the country it came from?
Yeah, that's all part of, that's a great question, part of the environmental investigation that we do. So in the case that Dr. Lioncello mentioned, when that turmeric was identified, we, of course, the first thing we did was, educate the family on that, to say, family, you've got to get rid of this. You can't use this as it's exposing your child. So the answer is sometimes. Sometimes if the spice is linked back to the country of origin, and in this case, this was a family of, it was a refugee family that had come in that was using a spice that they brought with them. And in that case, I mean, there's only so much we can do in terms of working with the family, letting them know not to use that. However, if we do identify that it's being sold locally or through some type of a chain store, there is work that we can do with MDR to try to identify that and flag that. Yeah. You're welcome.
Representative Kofia.
Thank you. Just a follow-up from Minority Vice Chair Wozniak's question about the areas where you're seeing sort of the flare-ups of more lead exposure. And I heard you say that it isn't necessarily that there aren't more in rural areas, it's that there's less testing in rural areas. Did I hear that correctly?
Correctly. And the fact that there are more children residing in urban areas.
Sure.
Yeah.
But so my district is a more rural district in northern Michigan, and I'm curious what I could guess, but that's usually a bad idea. Just tell me, what are some of the barriers for rural children to have access to this testing?
So what we've heard a lot directly from families is that transportation to medical care can be an issue. So that's not just a lead problem. It's, an overall well-child care problem. I think I would just generally sum it up with access to care, right? It's the transportation getting there, it's getting in to see a primary care physician, where are they going for their well-child visits. The WIC clinics have been, in the midst of COVID, shut down for in-person care. And so that's a barrier that I think if we could get those open back up in person, that would help in terms of getting families to care.
So they're not back up yet. Is there a timeline or?
Do you know?
I don't know that information. We'd have to get back to you for that.
Yeah, I would appreciate that. Thank you.
Yeah, that's important information. If you would, send it to my office, and I will be certain that the rest of the committee members get that information. Representative Thompson, and welcome. Welcome to the committee, your first day today.
Thank you, Madam Chair, and thank you for saying that. I'm very, very excited to be here. So my question goes back to, you said that the 2022 report will be put out with the 2021 report combined. As far as the last bit of data that you have as the children that were tested, how many of them were at a higher level than the 3.5 deciliters of the children that were tested? And then what year do you have that data from?
Yeah, so we have, we brought with us this is the fiscal year 22 data, which shows that 3,565 children were over the 3.5 micrograms per deciliter.
3,565.
65.
And you said you do have the
2022.
2022.
And just to reemphasize, this is also a time where the blood lead reference value dropped. So this is,
Because prior to that, it was at the 5, and
Yes.
then it went to 3.5. Okay, that's understandable. And then just a really quick acknowledgement of that WIC program. I definitely agree with our chair about getting that data. And right now, is the WIC departments just via Zoom for when families go on to qualify for their benefits? Are they still every 3 months? Do they log on to a Zoom meeting? Or how is that looking since the clinics aren't actually open for the families to go into?
Okay, we will find that out.
Are they still going every 3 months?
I will have to find that out for you.
Oh, okay. Thank you very much.
Okay. Well, thank you. Thank you, too, for being here. I don't see any other questions, members. All right. Well, and we don't have any absent members, so very good. So there being no further business before the committee stands adjourned. Thank you all.